Thank you, Steve, and thank you all for this great invitation and opportunity to be here. It is always a great pleasure to be in Ribeirão Preto. What I'm going to talk about is actually temporal lobe epilepsy, but not the temporal lobe. We'll talk about the temporal lobe in a little bit. And one of the questions, obviously, is why should we be interested? The focus for much of the research in epilepsy and the basic mechanisms of epilepsy has really been on the structures that are involved in what we think seizure onset occurs, which is also what we take out when we do epilepsy surgery. The hippocampus has been the main focus, and also the amygdala and the entorhinal cortex to a lesser extent. But as time has gone on, not just for temporal lobe epilepsy, but for many other forms of epilepsy, the thalamus plays a very important role in seizure initiation, as we will see. As we'll also talk about briefly, in TLE, there is clear thalamic pathology. It's not just a passive thing. There are changes in the thalamus in this particular syndrome that are clearly different from normal. One of the things which has been observed both in the animal models and in human mesial temporal lobe epilepsy is there's a clear diurnal pattern of seizures, both in the rats with chronic limbic epilepsy and in people with this. The seizures occur far more commonly in the day, especially in the afternoon, than they do, say, after midnight. So what that implies is that there is some sort of subcortical modulation of the system that shifts the pattern. So there's something that may be happening outside the temporal lobe, which is controlling when the seizures are occurring. And understanding how the system is modulated could potentially lead us to new ways of dealing with and treating epilepsy. And also, as you all know, in the recent years, there has been this great interest in somehow modulating the subcortical structures to treat epilepsy. The obvious one has been the Sante study, in which there was thalamic stimulation. The results were sort of mixed, although it was a positive result. It was not the home run kind of treatment that we would have liked. It really didn't stop anybody's seizures. And we'll talk a little bit later about why that might have been the case, because a lot of us really believe that somehow, because epilepsy is an electrical phenomenon, that if we put electricity back in the brain somewhere, they will be able to fix the seizures. At this point, we just don't know why or how. And understanding the extra-temporal circuits may give us some insights into why things don't work and how we might make those better. So in animal studies, too, there's been a lot of work on doing genetic therapy, doing transfections to insert new receptors for optogenetics and others, that you might be able to modulate the thalamic activity better. And one of the key points in that, as we'll talk about, is really finding the targets. What should you really be looking at when you do this? So one of the things to understand about temporal lobe epilepsy is that it really is, we sort of talk about it as the focus. There is a place where the seizures begin, and that's true up to a point. But if you look at the physiology, both in the human studies and in the animal studies, the different structures of the amygdala, the hippocampus, the entorhinal cortex, they are all capable of independently initiating the seizure. We know that if we look at the animals and in people, that there's pathology in all of those structures. But, that's an important point, the pathology is variable from person to person. There are reports out from Montreal, among other places, of amygdala sclerosis only. The changes are primarily in the amygdala and not really seen in the hippocampus. And others, the predominant pathology is in the hippocampus. It's also recently been shown that there's a new ILAE classification that's sort of working its way through the system that shows that, in fact, hippocampal sclerosis is not a uniform entity, but there are different subtypes of hippocampal sclerosis, and that subtype of hippocampal sclerosis really can influence or correlate well with the outcome from surgery. We know for a long time now that when you take out all of the structures, the amygdala, the hippocampus, the entorhinal cortex, that the outcomes are better. So it's not that just taking out the hippocampus will work every time. In some patients, it really does depend on taking out all of these mesial temporal structures. Again, suggests that this is a multifocal or diffuse seizure onset zone. And that we've seen lots of patients that had an unsuccessful first surgery because of incomplete resection, and they would come back for surgery later to remove the rest of it, and that surgery would be successful. So it really is just not a single entity. And the way to conceptualize this was published in the Annals a few years ago. If you look, if we can sort of point this out, there's the arrow there. If you look at sort of what we think is the seizure onset zone, which is the hippocampus, the perihippocampal gyrus, these are all areas that have been implicated in epilepsy seizure onset, the amygdala, entorhinal cortex, and the olfactory cortex. We don't talk about this much in people, but clearly in the animal models, there is pathology there, and it's very capable of generating seizures. If we look at sort of what we think of as the usual seizure onset zone, which involves, say, 2 or 3 of the structures, most resections, if you look at this black dark line, removes that whole area, and the seizures are controlled, and in some cases, they're cured. But in some cases, we think that the seizure onset zone, well, actually, we'll say, first of all, that when the resection is small, which happens in some cases, you don't fix the seizures because there are remnants left at the edges. But in some cases, too, the seizure onset zone is probably much larger, and a good resection still doesn't take out all of those areas. What's also known is that in mesial temporal lobe epilepsy, the pathology is often bilateral. Although we talk about it as a unilateral disease, the reality is in pathology that there are changes on both sides. And we sometimes see with intracranial monitoring that patients have bilateral and independent seizure onset. And although you can still successfully treat the seizures in some cases, it also is a sign that the surgery may not work when they have bilateral onset. So it is much more of a systems disease. And finally, what we'll sometimes see is that although they may have hippocampal sclerosis or the seizures may appear to arise in the hippocampus, there's actually a seizure focus that is somewhere outside, and removing the hippocampus has little or nothing to do with the seizure outcomes. So I think the point here is that in mesial temporal lobe epilepsy, you have the seizure onset zone itself is variable. It involves multiple structures actually, and it can be bilateral. And we think about that just in terms of the pathophysiology as we go forward here. So why the thalamus, though, and we'll talk about specifically. It was mentioned actually back in the 60s by the Morgerson and Corsellis monograph in Brain, that what they found was that in a certain percentage of the patients, when they did autopsies on patients who died and had clear hippocampal sclerosis, a certain percentage of these patients had a very obvious pathology in the thalamus, about a quarter of them. And this was just on gross review. There was clearly a sclerotic thalamus. In recent years, this is from Zahaba Yuhash and Hari Shagani. What they looked at was there atrophy? Because up until that point, there had actually been some reports that in PET scans, that a number of people noticed that ipsilateral to the abnormal hippocampus and mesial temporal structures, there was also hypometabolism in the thalamus. And what Saba showed was that very clearly, if you look at, again, if I can get the arrow, there it is, okay. This is the more sclerotic or the smaller hippocampus. What they also found is that what was the ipsilateral mediodorsal nucleus, and specifically the mediodorsal nucleus, that was atrophied as well. They've also found decreased flumazenil binding on that side. And other studies have shown, there was one from Montreal that showed very nicely that this atrophy of the thalamus was something that was specific to mesial temporal lobe epilepsy. We've seen this in the rat models as well. It's very commonly known that we have clear atrophy in the animal models of mesial temporal lobe epilepsy, the chronic models. And there's also pathology in the hypothalamus, which may get back to something that Dr. Kanner and Dr. Terra were talking about changes in the hypothalamic pituitary axis. So there is broad pathology outside of the temporal lobes that are involved with the epilepsy, with this particular form of epilepsy. If we look at seizure onset in these animal models, but also it's been shown in some people, these are from 2 different rats, and there is an electrode in the hippocampus, and this is an electrode in the thalamus. We see actually that there is very synchronized onset. In fact, in this one you can almost say maybe it's even leading in the thalamus, but there's very synchronized onset between the hippocampus and the thalamus, and the seizures proceed together very well. 2 different rats, 2 different seizures, and the same pattern is seen with the synchronized onset between the hippocampus and thalamus. There's a structural basis for this because, as we'll see in a minute, the hippocampus and the medial-dorsal nucleus and other limbic structures are very tightly linked with one another anatomically. And so it makes good sense that these things would go together. The first evidence I've seen in people was a report out of Marseille in which they had some thalamic nuclear electrodes in place, and in some patients with mesial temporal lobe epilepsy, if the electrode was in the medial dorsal thalamus, there was also a synchronized onset. So I think the thing we can say is that in limbic epilepsy, which is another word for mesial temporal lobe epilepsy, that there is a distributed multifocal cortical, which is the hippocampus and amygdala in this case, and subcortical system. That there are changes, that it's just not a focal disease, that it's a neural systems disease. And it's probably a better way to think of this. It's just not one place, it's multiple places that are involved. So one of the ideas is then, all right, you have this. We're interested in subthalamic or subcortical therapy, and can you then affect somehow the medial dorsal nucleus or the thalamus and affect the seizures? And so in this case, we were using some kindled rats, so we were stimulating the seizures, and we put a cannula in the medial dorsal nucleus, and we infused muscimol, which is the GABAergic agent. It's an inhibitory agent, so it will shut down activity. So if we stimulated the seizure here, and normally you see this nice long, and it was a stage 5 seizure, classic kindled motor seizure. If we infused the muscimol very quick and waited 5 minutes, we were able to really significantly suppress the seizures. In a few cases, we completely stopped the seizure. And even in these cases, the behavioral severity of the seizure was much reduced. They no longer convulsed in most cases. We waited again for 2 hours rather, and let the drug wash out. The seizure was just as it was before. So very clearly there was something about the infusion. Infusing saline has no effect on this. But what's also very important, and this is going to apply to a lot of other studies coming down the road when we think about how we might do subcortical therapy, is that the success is phenomenally site-specific. So if you look over here in this series of images or drawings from the rat atlas, from the Paxos atlas, the dots are where the seizures were suppressed. This is where the cannula tip was and the seizures were suppressed. And the X's represent where the cannula was when the seizures were not suppressed. And what you see is, in fact, that you have to be absolutely dead on. If you're off just a little bit, you'll have no effect. And that's what you see here, that inside the zone, if you're one of these dots, there it goes. If you're one of these dots, you had a very significant effect on seizure duration. If you're one of the X's, you had no effect on the seizure duration. And if you were you also suppressed the behavioral severity. There was some effect when you're outside of the area, but it did not achieve significance. So again, the efficacy, if you're infusing, and as we'll see later for stimulation, the efficacy of this kind of treatment is really, really tight. You have to be at the spot. If you're close but not there, you will have no effect. And it's one of the things to consider as you begin to develop these therapies. You have to know the circuitry, you have to know what your targets are, and you have to be right there. So, we know that we can modulate we can affect the medial dorsal nucleus pharmacologically, we can stop the seizures if we're in the right place. But what is the role? I mean, what does this structure actually do? And so that was one of the questions that's been worked on for a while. And one of the questions is, well, what is the relationship? We knew from a lot of good track tracing studies that this particular nucleus, the midline nuclei, had very strong or very significant numbers of axonal projections to the limbic system. And so one of the first things that we did is we looked here. The CA3, we're recording in CA1 of the hippocampus, which is the major one of the output structures, and we were looking at CA3, and in the rat, when you stimulate CA3, you can get a very potent evoked response in CA1. And so the classic stimulation in CA3, you see here a very nice response, good population postsynaptic potential and a nice population spike. When this represents when all the axons are firing off. So this is the postsynaptic potential here, and this is with the population spike when the axons are firing. What's interesting in the kindled model in CA3, this is actually somewhat reduced. In the epileptic animal, it's also reduced. It's not a very potent one. What we actually found is we stimulate the thalamus and record in the same area. The response is as great or greater than it was when you stimulate in the CA3. In kindling, and compared to one in course, it was a somewhat enhanced response. What's very interesting is you got a response in the epileptic animals that was very different. It was lower in amplitude in part because of the reduced neuronal population, but it was a much more prolonged with many more population spikes riding on top of it. So one of the important things to take home from this as well, besides the fact that the medial dorsal nucleus has a very significant input to the hippocampus, is that although we talk about the kindling model and the chronic epilepsy model as being chronic models of epilepsy, this evoked potential itself shows that the responses from the kindled animals and the epileptic animals are very different. That epilepsy has a very unique physiology that repeated seizures does not replicate. So kindling does not replicate all the changes that happen in epilepsy. We also looked at two of the other sites, the entorhinal cortex and the amygdala, and in both cases there were good excitatory responses in both areas. Then we also looked at, this is one of my graduate students, David Sloan, a few years ago, because we're now beginning to look at, say, well, how does seizures spread? And does the thalamus begin to play a role in seizure spread as well? And so we took one of the potential projection areas, and the medial dorsal nucleus does have very significant projections. Here's the medial dorsal nucleus down here to the prefrontal cortex in rats, which is kind of like the cingula gyrus probably in people. And as you can see, that stimulating in the midline down here and recording in these areas here, you see a very good excitatory response. And what's also interesting here is that you just also see the classic recruiting response, so that repeated stimulation, these are 4 stimulations at about 7 hertz, you see a very pronounced increase in the response by the time you get to the 4th. And this is, again, a classic kind of thalamic response that you would see. So one of the things in here is the thalamus not only has, this particular nucleus not only has connections to the primary limbic structures of limbic epilepsy, but it also has targets for where the seizures may spread. And in fact, although I won't show you this, this is one of the first areas that the seizures begin to show up in after they break out of the limbic region. So, I've shown you that inhibition of the medial dorsal nucleus can suppress limbic seizures, and that the medial dorsal nucleus has strong excitatory input to the seizure onset zone and the seizures and the sites of seizure spread, such as the prefrontal cortex. So it plays a role, it does something, but what is that role? And how does this actually play a role? Is it simply a pathway from point A to point B, or does it somehow also do something to enhance the seizure activity, to allow the seizure activity to happen? Can it be viewed as a control point in the circuitry? So, to look at that question, we wanted to look at sort of a system response in these animals. And so we wanted to look for circuits, and you'll see the circuits in a minute, which involved both the thalamus and direct inputs from point A to point B. And so we did two. We looked here at the subiculum, which is the major output center for the hippocampus, to the prefrontal cortex, and we chose that because there were well-known connections, monosynaptic connections between the subiculum and the prefrontal cortex. And we also looked at the piriform cortex, which is another name for the olfactory cortex, the entorhinal cortex, because the piriform cortex has both connections that are monosynaptic to the entorhinal cortex and also has connections to the thalamus. What you see here is if we stimulate, you see a nice response. If you're stimulating again in the thalamus, or actually, I'm sorry, one more. If you're stimulating in the subiculum here and recording in the prefrontal cortex, you see these nice responses. There's an early response, which is likely monosynaptic, and then there's a late response, which probably involves several synapses. Same thing happens with the piriform cortex to the entorhinal cortex. You see these early, brief, rapidly occurring monosynaptic responses, and then you see some late responses. The response that you actually see will vary from the depth of the recording, just because, and especially in the entorhinal cortex as you cross over. And so one of the things that we did as we did these studies is we chose sites in which we could see a reproducible response. And this is the one we chose at about 6.3 millimeters deep. It was fairly reproducible, and we can get these waveforms fairly consistently. And the same thing for the prefrontal responses. We chose one area where there were consistent responses in a very standardized and stereotyped pattern. So one of the questions was, can you separate these things out into possible different components? So one of the things that we did is we just sort of said, okay, we'll do the subiculum to prefrontal cortex. We knew that there is a monosynaptic response from the subiculum to the prefrontal cortex. We also know that there is a monosynaptic response from subiculum to thalamus and from thalamus to prefrontal cortex. So from this point going through the thalamus, there are at least two synapses, perhaps a few more, and there's a single synapse going from one to the other. The same thing is also true for the piriform cortex to the entorhinal cortex. There's this nice, very potent monosynaptic connection, and then there's there's a polysynaptic connection going to the thalamus. So one of the questions in sort of analyzing this is, if we're going to look for a thalamic response, when should it be occurring? So David Sloan, one of the first things he did was, all right, we can show here, if we stimulate in the subiculum, we can get this nice response in the thalamus, and there's a peak time. And so we could say that going through the thalamus, that you had to allow time to get from the subiculum to the thalamus before the thalamic response would begin. So when you add these times together, there's a time window here when it's the earliest possible time that you're going to see a thalamic component. So that's about, in this case, about 37 milliseconds. And we sort of use that as a timeline we'll see here in a minute. And so you can say that somewhere out here is where you can begin to see the thalamic component. These early responses are not thalamic, but somewhere in this area you're going to get a thalamic component of the response if it's there. Same thing is true. We did the same thing for the piriform cortex, the entorhinal cortex. And you can again see it's about 35 milliseconds or so when you should begin to expect a thalamic response. And so that's kind of where we drew these lines to say, all right, sometime after this is when we're going to see the thalamic response, if there is one. So we gave ourselves a time window. We repeated these things. This time we used TTX, which is a potent, it's the tetrodotoxin from the pufferfish. It's a sodium channel blocker. We use this to essentially silence the medidorsal nucleus. And as you can see here, these are anesthetized rats. We give them a stimulation here that lasts 10 seconds. Normally we get these nice long after discharges. When we infuse the TTX, in both cases, we can shut the seizures down completely, just stop them. And we know, again, it's site-specific. If we're a little bit off, it won't work. So again, TTX, in silencing the medidorsal nucleus, really has a very potent effect on the seizures, and we can basically almost stop them or completely stop them, as you can see over here by the seizure duration. And when you wash it out, the seizures come immediately back. So you can transiently block the activity of this one structure. So what happens, though, to those responses? So this is our baseline response here, and this is the subiculum to piriform cortex. And you use this as your thalamic response here, this dotted line. What you can see is when TTX goes in and the seizures stop, you significantly reduce this late response, and it may not just be thalamic, but there's a thalamic component to this, and you reduce it. And when the seizures recover, that component comes back. The same thing happens with the piriform to EC. You have a somewhat positive response here. That positive response disappears, and then it returns again as the seizures come back. So by inhibiting the thalamus, you change the late responses which contain a thalamic component. You can sort of see that here, the amplitude of the response after TT. The early response, which is the monosynaptic response, the drugs in both cases have no effect really on the response, whereas it has a very potent effect on the latent thalamic response. So in this case, in blocking the seizures by blocking the MD, medidorsal nucleus, you then also take the thalamic component out of the circuitry. And we can show that you're changing the evoked potential. What's also very clear is if it's not there, if you're not infusing in the right place and you're having no effect on the seizures, so if you, again, put these where the zeros are, where the open circles are, and you have no effect, you also have no effect on the evoked responses. So the seizures don't change, the responses don't change, and so again, this is a very site-specific activity, and changing the thalamic component of the response becomes a very important part of this. So, again, to summarize that, in complex limbic evoked potentials, which involve early and late components, suppression of the MD that does not affect the monosynaptic response, so that primary excitatory input from point A to point B does not get changed, but the late responses do, and that's where the thalamic component is. So somehow the suppression of this thalamic component correlates to seizure suppression. We're not going to call it causative for the moment, we'll just say it correlates. So in sort of trying to conceptualize what this means, that we're sort of talking now about a way of amplifying excitation. So what we are hypothesizing is happening is if you start here at the seizure focus, here, and from that seizure focus you get this excitation going both to the thalamus and one that bypasses the thalamus and goes straight to the target zone. What happens here, by involving the thalamus and allowing this secondary excitation to arrive, you are enhancing excitation, you are making the excitation last longer, and that enhanced and prolonged excitation appears to play a significant role in pushing the system over into a seizure. So the monosynaptic response by itself is not enough to cause the seizure to happen, at least in the kindling model. And it really requires this prolonged dual pathway period of excitation and push the system over into a seizure. And so we sort of talk about the divergent, convergent excitation amplification. The pathways spread out and then they reconverge at a target. So, and I think that's the way you can look at this, is that the MD nucleus plays a key component in that kind of amplification. It is, again, nucleus specific. If you're off-site, if you're not there, it doesn't happen. The circuits have to exist. So we talked a little bit about stimulation and trying to use stimulation. And there are thalamic stimulation studies out there which say there's a promise in the animals. The clinical trials have showed some effect, but it wasn't a huge effect. So what might be happening? So this is something we've been doing in the lab recently. And we're looking in this case at stimulating afferents to the MD. Although we're talking here about RTN, in fact, it's probably a little closer to, it's probably the afferents that are going into the MD. So what we do here is we stimulate the RTN, the afferents, if you will, for about, off and on, 4 minutes, 3 times over 15 minutes. And so then what we see is what the effects are on the seizures. And you can see here that when we finish the stimulation, we have some longer seizures here, and then the seizures then are significantly suppressed. And it takes about 2 hours almost for the seizures to return. And you look at it again here. This is the period of stimulation. And you can see in the animals in which the stimulating electrodes are on target, during stimulation, you clearly suppress the seizures. But then the seizures stay suppressed for quite some time afterwards. If you're not there, if you're out of that site, the sweet spot, which is adjacent to but not in the medial-dorsal nucleus, the stimulation has no effect. And I think that's a key point in all of this as we think about doing the stimulation studies or going forward with it. This is a phenomenally site-specific response. Not only is it site-specific, it's intensity-specific and frequency-specific, so that there is a certain pattern that you have to use, and lots of other things. If you just randomly choose things, won't work. There's a way of sort of looking at this. And one way of actually looking at this is a question of, are you changing the physiology? All right, and so we look at these, again, our responses. These are evoked responses. This is before stimulation, and you see this is recording in the dentate gyrus and the entorhinal cortex. And what you see is, before the stimulation, you see this nice response, a nice seizure. Then after the stimulation, what you'll see here is, again, the seizures are completely suppressed. What happens if you look at the evoked responses leading up to the seizure, you'll see here, in fact, that in both the dentate gyrus and the entorhinal cortex, the responses are significantly diminished following the stimulation. And again, it really is just true for when it's working. And if you look at it here in the entorhinal cortex, this is the baseline amplitude of the response over multiple stimulations, and you'll see here that there's a significant reduction in both the response in the entorhinal cortex, but even more impressively in the dentate gyrus. Compared, and then when these seizures begin to come back, the amplitudes again recover. So there's this transient suppression of the responses from this MD stimulation, suggesting again it's not part of the direct synaptic, it's not part of this pathway of in this case piriform cortex to entorhinal cortex, but clearly by changing its responses, and I'm not going to show the actual thalamic responses, but they are clearly suppressed. That really is what's changing the system and difference. So, stimulation of the MD afferents can reduce seizure duration. It reduces the evoked responses in the target areas, and again, the effect is highly site-specific. If we are a millimeter off, or if we are actually directly in the MD itself, we have no effect. So you have to have and understand sort of the anatomy and physiology of these structures. You have to be in exactly the right place for this to work, and it's not random. So, can it be a target for therapy, the MD? Maybe. But the one thing that you have to realize in this before you begin messing with it is that the medial-dorsal nucleus is a major component of memory. It's been shown in lots of animal models. If you lesion the MD in animals, You get a very apathetic animal, they often die because they just quit eating, they don't do anything. And we also know that in people who have had those rare cases where they do get these mediodorsal infarcts, they become very apathetic. And so you have to approach this target with great caution because the potential to have a major effect on overall behavior is very significant and you can't ignore that. So as we go forward in this, and I'll keep that in mind, the thalamus is a major component of seizure initiation and spread, and for limbic epilepsy, it's the mediodorsal nucleus. I think what we can say is right now, at least in this type of epilepsy, maybe in a few others, if you want to interpret other people's data well, and a couple of others, that it's part of a divergent convergent excitation amplification system. So again, it's that spreading out and reconverging and really prolonging the period of excitation. But these findings are specific for limbic epilepsy. If we're looking at other neocortical epilepsies, we'll probably have to decide, if we're going to look at the thalamus, what the connections are with those with which thalamic nuclei. So it's not going to be, the mediodorsal nucleus is not going to be a universal target for all forms of epilepsy in all likelihood. Because direct stimulation or because lesioning is not necessarily going to be of the thalamus, is not going to be a realistic option. One of the things that we need to think about now is how do these structures get modulated from subcortical structures. There is a significant input to the mediodorsal nucleus of GABAergic from the basal forebrain. There's a lot of hypothalamic input to the mediodorsal nucleus. So it's quite possible that somehow modulating one of those subcortical structures, other subcortical structures, may be a viable target. But that's going to come back again with more physiology and more anatomy to understand what the connections are and what roles these structures play in the system. So thank you very much.